Hello, 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 everyone. Welcome, welcome, welcome. Tonight, Dr. Andrew E. Lazar is our guest on Kidney Stories 2. He's a nephrologist with over 24 years of experience and the chief of the Department of Nephrology at AHA Medical Center in Beechwood, Ohio. He is the founder of Cleveland Kidney Disease Associates. He is board certified through the American Board of Internal Medicine in the fields of internal medicine and nephrology. He is also a nephrologist with CKD Associates. Dr. Lazar graduated from Wayne State School of Medicine in 1988. He was the chief resident in internal medicine at the University of Virginia School of Medicine in 2002. He graduated from Case Western Reserve University School of Medicine as a nephrology fellow in 2004. He has a degree in biomechanical and medical engineering and was a software engineer at one time for General Motors. He is the founder of Cleveland Home Dialysis, the principal owner of Peloton Medical Devices, currently developing a device for dialysis patient safety. He is the medical director for Renew Dialysis, nursing home dialysis group. He is the medical director for Dialyze Direct, the first to offer home dialysis in the state of Ohio. He is the consulting medical director for Natera, a global leader in cell-free DNA testing, promoting the use of genomics in the study of persons' genes and how they interact with a person's environment in the nephrology practice and in pharmacological research. Natera focuses on women's health, oncology, and organ health. With Natera, he has helped develop an expertise for genetic testing for kidney disease patients. That is the subject of our conversation for this evening. Please give a warm welcome to Dr. Andrew E. Lazar. Doc, how are you?
Okay, Jim. Doing really great. How are you tonight?
Doing well, doing well.
Good, good.
Did I correctly state all your credentials and experience in my introduction?
I think you did. Yeah, I thought that it was my mom maybe on the other end. Yes. Yeah, so engineering is my first love, and then medicine, and it's been a lot of fun bringing those together. And genetics is played into that, is why I trying to push our field, trying to take nephrology to some of the precision medicine that I think oncology has done and even cardiology is doing. And I'm really excited about where nephrology is finally heading.
Okay. I saw the broadcast that you did with the AAKP on genetic testing for your kidney disease, and you made a point in terms of diagnosis that doctors frequently make an educated guess at what caused someone's kidney to fail. Can you please explain what you mean by that?
Well, for those who unfortunately have to see a nephrologist, when you come to the office, I've always felt that rather than going right to big tests, if you listen to the patient will tell you what's wrong. I truly believe that. And so the key is history, history, history. And only then should we follow that with a really good physical exam. And only then should we start to reach into labs and radiology and genetic testing, yada, yada. So when I meet someone, a lot of time is spent gathering their history. And what are the other medical issues they've had? Do they have a blood sugar problem? Do they have target organ damage related to that? Do they have high blood pressure, cholesterol, the other things that we know affect blood vessels? But when all is said and done, we can do the best we can. And then with the physical exam, do we hear or see something that may point us in direction A versus B versus C? And then the radiologic studies, maybe it's an ultrasound, maybe it's a CT. Does that help us somewhat hone that down? But really, as well as we think we can do, we have to accept more and more that very often we don't know the exact etiology. We don't choose to do a kidney biopsy for probably most patients. Frankly, we should probably do more biopsies. But as hard as we try, and I like to stay humble. Probably one of my favorite quotes ever was actually at commencement at Harvard, where this particular speaker said, "Half of what we know is wrong. We just don't know what half." And that's changed my thinking about everything. We have to stay humble and take a good look at what we know and what we don't know. And I took a look at my practice and felt that for probably 30% or more of the people who I'm seeing, I can't say with absolute certainty. Now, often, Jim, it may not really matter. Someone has been very stable. They don't have protein in the urine. I can control their blood pressure. I can control their cholesterol. The blood sugars may be doing okay. And we're focusing on their eyes and all the general preventive health. And, I may not be able to say with 100% certainty what it was that led to their injury, but I feel good about how they're going to do. I may not look further, you know. But those who may not be going in the right direction, or they have certain prognostic signs or symptoms that may tell me that, there's a chance that this person may get worse. For the bulk of my career, we've had to throw up our arms. And there have been few things that we can do on the diagnostic side to go to the next level. And honestly, until the last few years, there have been very few things that we can do on the treatment side. First 10 years that I've been doing this, this being a second career, there wasn't a lot of exciting stuff going on the treatment side. Now, suddenly, Jim, we just have so many new therapies, whether it's polycystic kidney disease, which I'm afraid you know something about, or suddenly Alport syndrome, which we can chat about, or down the line, IgA nephropathy. It looks like we have some new treatments, and certainly you've heard about a lot of the medicines for diabetics. So we just have to face a fact that many who are out there watching, if you're seeing a nephrologist, you may want to say, do you know what has caused my problem? How worried are you that I may get worse? And if you are there other diagnostic things that we can do? For my CKD of unknown etiology, that we can look under another number of stones and see if we can get answers. Does that make some sense?
Yeah, yeah. Are we now capable of making a more accurate diagnosis, and why is that important as far as someone's kidney failure is concerned?
Well, more and more, we have treatment options for which, if we truly knew the etiology, we can pinpoint therapies a little bit better. Just to take a step back, when we look at, let's say we have drug A, and we enroll 1,000 people in a clinical trial, and the best run clinical trial, a prospective randomized controlled trial, would be we have 1,000 people and 500 are in group A, 500 in group B, and the best possible study would be that the only difference for treatment between group A and group B would be the addition of, let's say, that drug X, that everything else would be exactly equal. You know, it never works out that perfectly. But when you look at trials, let's say the outcome of the trial that I describe, that there's an overall benefit. Okay, that there's, let's say there's a 20% relative risk reduction that someone's kidneys are going to get worse. But unfortunately, when you put just 1,000 people with a chronic kidney disease, all of the benefit that you see mathematically, maybe for a relatively few number of people. In theory, other people may be exposed to harm from that drug X. The point that I'm making is that we have to get to where we can treat people on a more precision nephrology basis, and using tools like, I hope, genetics and maybe more intelligent processing of kidney biopsies and what's called proteomics, where we can look in the urine and look in the blood and look at proteins, which are the product of genes. These are the types of things that we're trying to do. And there are a lot of different projects out there at academic centers that we can start to get a better idea as to not exposing, let's say, all 1,000 people to that drug, because, you know, again, at the end of the day, there was a benefit, but there was benefit to just more people than there was, let's say, harm. So, you know, it was a net benefit. But meds are typically going to have a downside. So we just have to, in 2022, in our field, like they've accomplished in some respects in oncology, get to where we can try to approach a real precision nephrology approach. Does that make sense?
Yes, sir.
Great.
Should a kidney patient consider genetic testing for their kidney disease, and are there a particular group or groups of patients who should definitely test?
So that's a great question. I absolutely feel that genetics are ready for prime time. I use a particular product with that company, Natera, called Renasight. And it's certainly something that you could ask your nephrologist about. Renasight is a panel of 385 genes. Now, the human genome is around 20,000 genes. We've identified over 4,000 genes that, when altered, are associated with human disease. About 625 genes that, when altered, can be associated with kidney diseases. Well, Renasight takes it down a little bit further to 385 genes that I have someone give a saliva sample that goes to the company, and I get back a report to look at alterations in one of those 385 genes. And I have found that when I look at some of the higher risk group people, the high risk people in my practice, and that would be people who have protein in the urine, people who have blood in the urine, or both, people who have kidney cysts, or certainly people who have a positive family history. So if you're out there and you fall into a group where someone in your family has had a kidney problem, you are at much higher risk, much higher yield that we will get a positive result when we do one of the Renasight tests. If you have cysts, there's a much higher chance that you could have polycystic kidney disease, and you have probably heard of PKD1 or PKD2, that you could have Alport, and that's one of the collagen 4. Collagen 4 is on that glomerular basement membrane, that filtering system. I think with broad genetic testing, we may learn that Alport could be the most common genetic problem that we see. It's just that we haven't been able to find it as easily as we have polycystic. So again, family history, please ask your doctor, hey, I'd like to have one of those renocyte tests. Cystic disease, protein in the urine, blood in the urine. Or if your doctor senses that you seem to be inching in the wrong direction and they truly don't know why, that to me is also relatively low-lying fruit to say, I think we ought to do genetic testing, because we suddenly have specific drugs for genetic diagnoses. And we that's kind of one column. That's one category. We also have a second category where we can make a genetic diagnosis now. And while we don't have an exact treatment for that genetic problem yet, it will alter the way that we treat you. Right now, if I learn that you have Alport, we hopefully are close to a treatment or two that are going to be specific for Alport. But although we're not there yet, there are a number of things that I'm going to do now. For one, I'm going to start looking at family members. Two, I'm going to look more closely at your eyes for vision, at hearing, at other potential problems that we could see should you have Alport. And I'm going to be much more aggressive with certain antihypertensives. So it's going to change what I do by knowing. So column one, specific treatment now for this genetic disease. Column two, it will still change what I do. Column three is there are dozens of trials where we identify with someone or identify someone who has genetic disease X. We can enroll you right in those trials. This is our way forward, that soon that disease is going to move all the way to column one, where we have a specific treatment for that genetic disorder. So those, if you're out there, and again, the family history, the protein, the cysts, blood in the urine. Blood in the urine, don't forget, you probably need to see a urologist to make sure that the bladder and the ureters are looked at and that you have a cystoscopy. We don't want to miss a lesion. But once that's ruled out, and maybe even in addition to blood in the urine, you've got to think about genetic testing.
Okay. I've heard you say that 10% of affected adults have a genetic cause for end-stage kidney disease, and only 10% are aware, and 57% of those people are at stage 4. If you have someone in your family that's been on dialysis, a relative that's been on dialysis before you, there's a 7 times as high a risk that you will end up on dialysis yourself. If there is a significant family history, what is your opinion concerning the necessity of genetic testing and involving other family members?
So those are great points. And just to clarify that, so CKD, right, chronic kidney disease, 30 to 35 million in the US have that CKD. And like you said, when you look at one study from only a couple of years ago, only 57% knew that they had CKD stage 4, which means that they are already in that GFR less than 30% of normal, And when you look at our dialysis data, and you've heard of the USRDS, that when I read the 2020 report, that still today, 2020, 1/3 of patients who started dialysis had never seen a kidney doctor. So that's how late in the game, unfortunately, we get to see people. So when, sadly, when I'm rounding at a dialysis unit and I'm talking to someone who's on a dialysis chair, I still want to know why they landed on dialysis. Now, for a few reasons. Number one, I still want to lower their risk. I want to lower cardiovascular risk. Maybe they have extra renal problems. Again, I'll tell you about a couple of trials about, you happen to mention Alport's collagen 4, and you mentioned 10%. I'll tell you about where that comes from, that number. That I had met someone not that long ago at my dialysis unit who was not my patient. He was very young. And he wasn't absolutely certain why he was on dialysis. And we did genetic testing, and he turned out to have X-linked Alports. Hadn't had appropriate vision testing, hadn't had hearing testing. But then, more importantly, maybe, or certainly equally important, he has two sisters who both have sons living in Michigan. So they were in the next state over. Well, when I'm looking at someone in that dialysis chair, I'm not only responsible for them, I am responsible for the people, the other people linked to them genetically who are at higher risk. You brought up a great number there that when you look at the literature, someone who has a first degree relative who's on dialysis, they themselves now have a 7 times higher risk to land in that dialysis chair too. So in here we harp on this notion of
Doc, we got problems with our sound.
Are you not hearing me? Are you not hearing me?
It's fuzzy. Can you log in and log out and log back in?
Okay. I'll try that.
Sorry, Steve. Are you there, buddy?
Yeah, I'm here.
Aye. How's his sound coming across to you? It's okay? All right, I'm sorry.
Okay. Better, Jim?
Yeah, a little better.
Better?
Okay. Let me ask this. You mentioned prior about the TIES study and finding out that 20% of the 5,200 patients or so that was involved in that study, they had an unknown or an uncertain diagnosis. Under these circumstances, how does genetic testing answer the concern about an undefined diagnosis?
Well, let me share with you the study that you were alluding to. In early 2019, there was a study in the New England Journal, which you've all heard of, one of our more important medical journals. And they looked across the board at 3,300 patients, about 65% of whom were already on dialysis. They didn't ask other questions. They didn't try to tease out any other risk factors, and just across the board, they did one of these Renasight-like studies, a broad genetic panel. And they found across the board that 9.3%, close to 10%, like you were quoting, had a genetic etiology that landed them in the state that they were in, and again, 65% of whom were on dialysis. And what were the problems they had? Polycystic kidney disease, collagen 4 disease, Alport. They had other problems you may not have heard of. Can you hear me still, Jim?
Yeah, I can hear you.
Good. And they had other problems you may not have heard of. That some of the proteins that code for that really complicated GBM, glomerular basal membrane, problems what are called INF2 and TRPC6. And so this 20% that you mentioned, and I'd say in my practice, I'd say it's more like 30% or higher when I'm really trying to be humble of the fact that I don't know the etiology of much of what I see. These 20 to 30% have these problems. It's just that they can look completely different patient to patient. We don't always have, they don't always present in a textbook way. So that's where that 10% comes from. That across the board, we'd say, 10% of adult chronic kidney disease has a genetic basis. I would argue that it's higher. I would also argue that what we're going to learn going forward, Jim, is that tonight we are just talking about monogenic genetic changes. You have a polycystic kidney disease, one gene problem. You're not making polycystin 1. It manifests as disease, fine. We are going to learn that monogenic, that's one problem, but we deal with day-to-day more of a polygenic problem where we have predispositions. There are all sorts of genes combinations that place one at risk, and others that actually protect patients. I could tell you, I just saw a paper this week that found genetic mutations in one's adipocytes, their fat cells, that completely determine what cardiovascular risk they are at. One can have a significant amount of fat tissue, and some are at much greater risk than others. We are starting to learn that it may have to do with the type of genes that they have that encompass their adipose sites. So this is where we're heading, that the day is going to come that I can see someone who is a diabetic and I can do Renasight, let's say, but I'm going to get a more interesting clinical risk score that may be the combination of 20 different genes that are on and off, and I'll get a clinical risk score for my patient who has diabetes to say they're at very high risk of kidney trouble and cardiovascular, medium or low, and it's going to change what I do, and it's going to change where I focus attention.
Okay. Can you talk for a minute about the pros and cons of genetic testing over biopsy or opposed to a biopsy?
So biopsies, I think we probably are going toward not doing enough biopsies relative to what we do. One problem is that we don't have a standard of care for when we ought to do a biopsy. And I read a paper about a year ago, it may have been less than that, it may have been presented at the ASN or the last NKF meeting, suggesting the importance of coming up with guidelines for whom we ought to biopsy. Now, more and more, I may want to biopsy someone, but they're on anticoagulation, right? More and more people are on Eliquis and Xarelto and these drugs for reasons X, Y, or Z, and then there's great risk. You have to hold it, and then there's a risk of bleeding, yada yada. So, but I think that we need guidelines to doing biopsies. Now, that being said, I would not in 2022 ever do a kidney biopsy without doing genetic testing with it. There are certain diseases, and I know I keep bringing up Alport because it's so important and probably the number one thing that we miss in my field, that genetics is considered the standard of care over a biopsy. When we do a biopsy, we of course get a very small sample, and you can get sampling errors. Sometimes we do a biopsy and the person goes through all this risk and we end up getting medullary tissue and we don't even get filtering units to even look at. So there's a real advantage when you do a biopsy to go ahead and include that genetic testing. Now, you've probably heard of that problem, FSGS. So FSGS, that fibrosing scarring kidney disease problem, just to share some of the data with you, there's a registry called the Toronto Registry, which is probably the best FSGS registry we have. And when you look at their data, that was over at least about a 20-year period. And they looked at genetic testing, and they found that for all comers in their registry who had FSGS, one of, if not the most common finding that we get when we do a kidney biopsy, for all comers, 11% had a genetic etiology for their FSGS. For those with a family history, 28%. That's how important it is that we not, you're going to do a biopsy, you're going to get FSGS back all the time. And then you're going to, I need genetic testing to go to the next level of understanding. FSGS happens to be one disease where suddenly we're getting a little bit more intelligent, where we're trying to break it up into 4 different groups. The old, what we call primary FSGS, which is a permeability factor problem that we haven't identified yet. We have a few maybe substances that we think could be the smoking gun there. Secondary FSGS, genetic FSGS, and then FSGS of unknown etiology. So I think that genetic testing adds a lot to a kidney biopsy. You've heard of, for example, Fabry's disease. That's one that we all fear and that I think that we miss very often because we don't think of it. That's one that the biopsy, you should see particular foam cells, but you don't always nab it when you do a biopsy. To add genetic testing, is another safeguard to not miss these types of problems.
Okay. One of the criticisms that I've heard about genetic testing are the costs, and if it's covered by commercial insurance or Medicare or Medicaid. Can you speak to that as things exist now?
Yeah. And that's a very important problem. And I care about costs. I really care about costs to the patient, but I also care about costs to the system, you know, and this era of value-based care that is here and now. So, you know, we really have to think about it. But I think what now I am not an expert on the cost side. You know, I'm more on this kind of science academic side of it. But having done a lot of genetic testing and, you know, caring about it for my patients, when I do it with this particular company, Natera, I know that for them, their max cash out of pocket that the patient would ever be responsible for is $349. Now, that's not an insignificant amount of money for a lot of people. So I don't put, but what I've been so happy about, and the reason that I like using them, is that for most patients, I find they end up getting it because they look through their family income, and for most patients, they get it for $0 or $99 max. Now, right now, Medicare and Medicaid, there's no cost to the patient. So, and that's really most of my patients, you know, but the commercial pay patients, I have one patient who I think were pretty well off, and they paid the full $349. And I was even upset about that. I told the company, you know, I would have liked to have known that prior to have that conversation with them. But I think the cost is really coming down. I think the cost to the patient is, and I think that genetic companies are working out what they're going to be asking of Medicare. And I think that some of the numbers I've heard thrown around are cheaper than, or half of what it would cost for me to order an echocardiogram here at the Cleveland Clinic. So and we do these things over and over again, willy-nilly, without thinking. And I can do a genetic test once because it's not like the patient's genes are going to change, you know. One time, it probably half the cost of an echo that I order sometimes 2 or 3 times in a year period because I'm worried about valvular disease or they have amyloid or what have you. So I think the cost is really coming down, and the accessibility with companies like this, Natera and Renasight, is really getting to where I think it's ready for prime time.
Okay. I want to talk to you about some of the cases that you've experienced in your own practice. The case I would like to start with is the FSGS case and mother and son. Can you tell us a little bit about your experience with that, please?
So I think there was an FSGS case that I had shared with that group that, if I'm remembering, was a 35-year-old gentleman who came in who had a creatinine, and I'm sure many patients know what their creatinine and their GFR is. Well, his creatinine was 1.5, and he had protein in the urine. Now, not nephrotic, so not more than 3 to 3.5 grams daily, but it was still rather significant, 1.5 grams, 2 grams over 24 hours. He had a biopsy, he had FSGS. I want to make sure that everyone knows that if they're told that they have FSGS, that's not enough. Do not accept that. You want a better understanding. You want to say, well, doc, tell me a little bit more about what you think the cause is, because there are dozens of different disease processes that will converge on looking like FSGS, which is a pathologic pattern picture under the light microscope. So that's where, again, you know, there are genetic causes. Alport can look like FSGS. There are a host of different diseases that we used to think had a particular pattern. When you look at the biopsy, no, they all converge on looking like this scarring FSGS problem. So this particular gentleman, the first order of therapies for people with FSGS tends to be putting them on prednisone. And it's not a little bit. Depending on someone's weight, they could be on 60 milligrams a day more. And you typically want to make sure that someone is on prednisone for 16 weeks or more to make sure that they've had a good shot of treatment. So anyone who's been on prednisone out there knows that it's not without side effects to the skin and cataracts and to their cholesterol, and they may get lower extremity edema and their blood pressure. They certainly gain weight. You know, you don't want to willy-nilly put people on prednisone. So this gentleman, though, he was on prednisone. blood sugars went up, looked like he was going to develop diabetes, sadly, was taken off of it and put on another more significant immune suppressant. Didn't have any improvement. So one in this setting has got to start thinking in 2020, what are the guidelines for FSGS and glomerular problems? Genetic testing should be considered for anyone 25 years of age or younger who have persistent proteinuria or FSGS. Any patient who hasn't responded to corticosteroids, you must think about it. And lo and behold, this person had a broad genetic panel like Greenosite, and indeed had a genetic cause for their FSGS, a particular protein called INF2. That is one of the proteins that make up this zipper-like membrane that is that GBM that I keep alluding to. So, well, now you have to take a step back and say, gosh, if I had done that sooner and I knew, I would know that this patient is not going to benefit from the steroids. What I did is put this person in harm's way. All the side effects, the blood sugars, the cardiovascular risk, future cataracts, avascular necrosis to their hips, then to cyclosporine, to a not insignificant drug that we use for kidney transplant patients. If I had known, I wouldn't have exposed that patient. And let's say the patient fails and is heading toward transplant. Well, with FSGS all comers, I'm going to worry that 30% or more, depending on the trials you look at, of FSGS are going to recur 12 to 15 months out of transplant. So I'm going to do other preconditioning regimens and pheresis and all this, but I wouldn't, knowing that this is an IF2 genetic case. So vital to have known and wish that we had known it prior that this patient had a genetic cause for the FSGS. I think that that's the case that you were referring to, Jim, right?
Right.
Good.
The other case, the next case that I'd like to talk to you about is the IgA patient and the reclassification that came about through genetic testing. There was something about dent disease. Can you tell us a little bit about that?
Right. This is a great guy who I just, he's a wonderful, he's probably 50 now, and I met him back in 2018. And he is from Scotland. He's the head of sales for a Fortune 500 company. So he's traveled a lot, lived in a lot of places. And back in 1991, he had a kidney biopsy in his native Scotland and was told he had IgA nephropathy. Now, IgA, I think we are getting a lot savvier at understanding its physiology and starting to come up with a lot better treatments for it. But he's told he had IgA. They did all the right treatment things. He was treated with fish oil. For anyone who's had IgA out there, fish oil is, something for which the data are a little bit plus or minus. He got fish oil. He was on lisinopril. So I met him. I was probably his fifth or sixth nephrologist while he's moving continents, and I'm treating him along the usual IgA guidelines. Creatinine staying right around 1.8 to 1.9. And I think things are going okay. He has protein in the urine. I'm not happy about it. I'm very aggressive with his RAS inhibitors, right? The ACE inhibitors, the angiotensin receptor blockers. And there was some data looking at Plaquenil, hydroxychloroquine, and IgA about 2 or 3 years ago. And, the data weren't great, but he was on that. And not really suddenly in January 21, creatinine heads up to about 2.2. And the protein in the urine takes off. His protein creatinine ratio became over 3. I really got worried. What am I treating here? This is one of these, again, Jim, like you're talking about, we have to stay really humble and nimble. And I don't know if I'm barking up the right tree here. He's not acting like he has IgA. He certainly doesn't have the aggressive IgA that we call crescentic IgA, because he'd be on dialysis by now. So what does he really have? I send one of those Renocyte panels, and lo and behold, it comes back. He has something called dent disease, X-linked hypophosphatemic rickets. Like, son of a gun. First thing I had to do, if I'm being honest, is what the hell is dent disease again? I knew it the day prior to my boards, but we think we don't see these things. We do see these problems. We just don't diagnose them. Now we are starting to see them because we can do genetic testing. And so, but this problem, now that I unearthed it, we took a different approach. He's on potassium citrate, and I look back through his ultrasound, and he does have what we call nephrocalcinosis, and he's on now a thiazide diuretic. And so it changed what I did for him. And he was always worried, are my boys going to get this? I have two sons. How wonderful that I could tell him, you know what, you have an X-linked problem. This is going to likely pass over your sons. I just feel really great that I can make a diagnosis, potentially enroll him in trials, be more intelligent about how we're going to treat it, and actually be able to give him family advice, which is what he was probably more worried about. You know, I mean, we as parents worry probably more about the kids certainly than we do ourselves, right? So that was a gratifying feeling.
Okay. One other of your cases that's near and dear to my heart and has to do with donor eligibility. You had a 60-year-old PKD patient whose son wished to donate to him. And as you know, Doc, they try and discourage us from donating within the family if we've been diagnosed with PKD. The question was, can he safely diagnose to his dad? Can you talk to us a little bit about that case?
Right. Yeah, and I think that I may not remember the details of that one as well, but in general, with PKD, yes, this was a 60-year-old. I think his son was only in his early 20s, and he said, I want to give a kidney to my dad. Dad said, no way, we can't say with certainty. Well, he had an ultrasound. The ultrasound looked okay, didn't look like he met criteria. Well, that young, we can't say with absolute certainty by kidney ultrasound that his son does not have PKD. So that's where doing genetic testing was 100% essential. Now, most transplant programs today would say you have to, regardless of the ultrasound appearance, you've got to do genetic testing for any potential donor who is linked genetically to that potential recipient. And indeed, his son did not have the PKD1 that his dad had. So suddenly, there's a lot of high fives and tears, and it was all systems go that dad can actually, that son can actually help dad. So PKD is a fascinating area. We are learning so much, and it's something near and dear to your heart, and perhaps a lot of people who are on this call, and it's very exciting also that we at least have some treatment for it. You've heard of that tolvaptan, vasopressin antagonist, Ginerq, that being a therapy. That drug bardoxolone, is in treatment trials right now. So, and I'm hoping that we have more in the pipeline. And with PKD, I personally encourage any doctor when they see someone who has cysts, and even if they think, I know what this is, and yada yada, I still encourage them to get genetic testing. Well, there's a few reasons why. If it's PKD1, we know it's probably going to be more aggressive. The average age that one may land on dialysis is definitely going to be younger, maybe in the 40s, where it's going to be, or the early 50s, depending on the studies, where it may be in the 60s for those who have PKD2. Now, even for PKD1, though, I want to know the next level. Do they have a truncating mutation, which is worse than a non-truncating mutation? And some of the classification systems that we use, Jim, to say how at risk is this person, and one of them is called the pro-PKD score, where you get a point for being a man, so that's bad. You get a point with hypertension. You get a point if you had some other PKD problem younger than 35 years old, which can be a kidney stone, for example. And then you get 0 points if you're a PKD2, 1 point, a PKD1 non-truncating, 2 points for a truncating, or, it may be 2 and then 4 points. So basically saying that you need to know what the genetic mutation is to even use that risk scoring system. But what I am finding now, and this is what's so neat about what they're doing with this Renasight product, is that they have done, I think, over 15,000 now. And I was talking to one of their genetic counselors the other day, because I lean on them quite a bit. And they were telling me I had someone who had a cystic problem. It looked like it's going to be polycystic kidney disease. I order Renaside, PK, it comes back negative. But they have this genetic problem that I had never heard of called IFT 140. What is IFT 140? I called their genetic counselor and they said, you know, you won't believe it. We have unearthed, I think now, over 100 cases that of a cystic kidney disease, which is this IFT 140. Now they're working with a group who had published something recently, and through this Renaside product, they have discovered what may turn out to be the third most common cause of cystic kidney disease. And then you start talking about emerging therapies. So this is why doctors have to do more genetic testing, because it's going to change some things for the patient now, but it's really going to change our field going forward. Because here, maybe we've discovered the third most common cystic kidney disease. Here we can identify people to enroll in trials, you know, to really move our needle forward.
Okay. Doc, we had a question from a member of our audience. Our friend Charles is asking, how does he retain your services? How does he get in touch with your clinic?
Well, yeah, and I definitely want people to feel free to reach out to me by email. I'm trying to think of the best email so that I can connect people, and I can, you know, again, connect with a genetic or connect you with a genetic counselor. You know what, you can feel free actually to reach out to me at andrew.lazar@clevelandkidney.com. Our website, it's a little bit older. We're trying to update it, but we're going to be adding genetic stuff to it. And but you can reach out. You can go online and Google Renasites, and you can get also to a local genetic counselor, and you can reach out to that company, Natera, directly, and you can ask your doctor about genetic testing, about Renasite, but certainly you can feel free, you know, to reach out to me. I saw that someone had a question up there about clinical trials. That's the other nice thing that they're doing. I've been leaning on this company so much because I have found that they have, through their portal, a clinical trial bridge. So if I get a genetic result, through their portal, I can link directly to a clinical trial that may be going on for complement disease, or there are a number of IgA. The other interesting thing is that, and I know I'm going on and on beyond the question you asked, but what I'm finding, you know, is that I may have a patient and I do genetic testing, and they had a biopsy. They turn out to have IgA. Well, you know, Natera, they may have a bunch of genetic tests that are negative, but now they've kind of collected a group of patients who may have IgA, and they can direct those patients to clinical trials for IgA that may not even have to do with their genetic test results, you know. So yeah, you know, it's a forward-thinking company that through which I think people can get to trials.
Okay. You mentioned board-certified genetic counselors. Can you explain what that is and how they help kidney patients? And I think the example I've heard you use is on oncology and kidney cancer.
Right. So, well, you know, it's funny you bring that one up. There's a genetic problem called von Hippel-Lindau, a genetic change in that VHL gene that's associated with renal cell carcinoma. Now, you know, I won't say it's super common, but you know, again, the more we're doing genetic testing, the more we're really unearthing things. That disease entity happens to have a particular drug now, you know. Wait, now your question, to get back to it, I want to make sure that I circle back to it. Your question specifically was
about board-certified genetic counselors.
Right.
How do they help people?
Thank you. So
what are the benefits of their services?
Right. So and you happen to mention that the oncology and renal cell carcinoma piece, so that when I get a test result, and I'll tell you, nephrologists in general, we are we are afraid of genetics. We were not trained in genetics. So it's really incumbent upon all of us to do a little bit of the reading on our own. But I've been so excited is why I'm trying to be an advocate and a partner for all of my colleagues to try to educate and, kind of share what I've learned, not only, in the literature, but clinically. But, we don't get a lot of training. So when I get a result, I have access to a genetic counselor right on that Renasight result that I get. I pick up the phone and I get a brilliant genetic counselor who is trained specifically in medical genetics to assist me. And I feel that that is crucial. And the patients have access to that genetic counselor too. And that's pretty cool, because
Yeah.
as frightened as I am when I want to order genetics, imagine how the patient feels. So then it's pretty neat when I get to talk to that genetic counselor, and then I can talk to the patient, and then the patient has that same access, and they can go full circle.
Okay. If someone wanted to utilize your services and they lived outside of the state of Ohio,
Mm-hmm.
could they have blood, bodily fluid drawn someplace else and sent to you guys?
We can certainly, again, Andrew.Lazar at clevelandkidney.com. Feel free, anyone, to try to reach out, and then I can tell them what I think they ought to do. Genetic testing is available at everyone's nephrologist office. They all have a rep. I think that this company, I think that Natera's probably got like 75 reps covering the entire country and 45 genetic counselors. I mean, they are really, really serious about moving the needle, in our field. So they can get this saliva or blood test anywhere at their nephrologist office. But feel free to send me the email. I'll try to help turn people on to perhaps who their local nephrologist is. Now, if they're near an academic center, they may also be somewhere where there's a genetic center of excellence too, where they actually have a nephrologist who is specifically trained in genetics. I happen to be lucky here at the Cleveland Clinic. We do have Dr. Wang, someone else who I can lean on.
Okay.
Oh, you know what? Just to change that, that's Andrew.Lazar at clevelandkidney.com. So it's not Cleveland Clinic, but it's Andrew.Lazar at clevelandkidney, all one word.com.
Okay. What happens in a situation where I feel very strongly I want to undergo genetic testing? My doctor's not so hot on it. What do I do?
Well, that's a great question. I think that I believe through Natera, patients can actually order it themselves. I don't know what that means from the reimbursement side of things, or whether they have to pay out of pocket. I believe, though, if they're Medicare or Medicaid, I have a feeling that they can probably go directly, and they can. And I think Natera, because it's so important that they want to make sure that people have access to this Renasight, I think there's a direct to consumer approach. So I really, I'm remiss in not knowing their exact website because I love their product so much. But if they went on Natera.com or Renasight, if they search it, I believe that we can get them to the right site. But I think that people can probably go directly and order it. But I would say appeal to their doctor. I hope the doctor is humble and kind of open to the notion that maybe they haven't been that trained that much in genetics, and share with them a little bit of what I've shared tonight about their concern about their family history, or they have kidney cysts, or doctor, you told me I had protein, in the urine, or I had blood in the urine, or we're not exactly certain why I have chronic kidney disease. I'd like to go to that next level. Please, if you could do this genetic test, odds are the test is going to be negative. When you consider the yield of the first 75 tests that I did, my yield was just under 20% were positive. Now, that's actually a very high yield compared to just about any other test that I order, right? So, the yield can be pretty high, but still that means 8 of 10 were negative, So I try to get doctors to have it not discourage them, because I personally get a lot of value from a negative test. When I can sit down with Mr. Myers and say, we looked under another 385 stones, and I didn't find the cause. But you know what? That's actually a reassuring thing. I know you don't have these things, and that not only should reassure you, but that your children and your grandchildren and your nieces and nephews, they shouldn't be at greater risk for any genetic reason for what you have.
Okay, we're in the home stretch here, Doc.
Mm-hmm.
Tell us, is there anything new in the field of genetic testing? Is there anything tonight that you didn't get the opportunity to talk about that you would like to speak about before we conclude?
Boy, I think that I think genetics in general is it is not a sci-fi topic anymore. It is not this. What's crazy, Jim? Is that not that long ago, it could be $1 million to map someone's genome. I mean, you go back not much more than a decade. That's how much the technology has come along. That you can map my entire genome for a little bit of money. I mean, $1,000, which was literally probably $1 million. I mean, so this is no longer a Star Trek level sci-fi test. It really is very attainable, with a report that makes sense and a reasonable number of genes that cause the problems that we see, and it's ready for prime time. Do we have a lot to learn? Yes. It's still what I would consider some of the more exciting leading edge things that we are doing, but it's only through doing genetic testing that I think we are going to go to the next level of treatments. And the more genetic testing we do, the more data we get, and we allow machine learning to have its way with all of this data, we're going to make the associations that we need to make so that our nephrologists can make diagnoses a lot more clearer and understand clinical risk, and we can get to that precision medicine place. So I think genetics in general is the leading edge, but it's really ready for prime time.
Okay. Dr. Lazar, I thank you for taking time to talk to us tonight. Very instructive. I'm sure everybody learned a lot, and I certainly appreciate you coming on the program to speak to us. Thank you so much.
A big honor, Jim. I really, really appreciate you, okay? And I hope you reach out again sometime, all right?
Okay. Have a good night, Doc.
Okay, everyone. Take care.
All right. Thank you. All right. Show's coming up. Shane Blanchard, February 11th. Shane's going to talk to us about his third kidney transplant. This one seems to have taken. Colin Clifford, a friend of mine from Ireland, is going to talk to us. He's had 3 kidney transplants in a foreign country. He works for a company that makes tacrolimus. So that ought to be interesting. Ben and Jasper, a couple of artists, are going to be on the 19th. That's the very next night on Saturday. Your Uncle Jim's going to have to stay up to midnight to interview those guys. One of those guys lives in Germany. One of those guys lives in Vienna. They had a kidney transplant that one donated to the other. They had 2 failed occasions where one guy's in the hospital, doesn't understand the language, doesn't understand what's going on. All he understands is they sent him home. So it should be an interesting interview. Tom Offner on the 25th is going to talk to us about his kidney issues, his kidney transplant, and also his kidney advocacy. So watch this space. We got a lot of interesting shows coming up. I'll talk to you soon. Have a good evening. Bye-bye.
side. CJ Ike, now I gotta roll with ice. Cold, these brothers my guys. Know that they fly, know that they ride or die. I keep boys by my side. CJ Ike, now I gotta roll with ice. Ride or die, ride or die.